Yeah, it's a pleasure to be here, and thank you for inviting me to do this. I guess we'll go ahead and get my presentation loaded and go ahead and get started. Great. Thank you, Billy. And that's me, and I'm Dr. Casper. And the title of the talk is Private Dermatology Practice with a New Multidisciplinary Approach for Non-Surgical Skin Cancer Treatment. And I'm going to kind of go through why we decided to do this and how it's working for us. And it's been really successful. Had a lot of patient satisfaction, and the results have just been absolutely magnificent. I wouldn't even say the results have been good. I classify the results as magnificent. And just to clear, I have no financial disclosures, and I'm not a paid speaker for IntraOp or any other company. So this presentation does contain images that are confidential to the company. And so I ask that nobody copy these images, disclose them, or disseminate them unless I give written permission. So again, I have no financial disclosures. So just the talk is just going to kind of run through. I'm just going to talk a little bit about my practice and the services we provide. I'm going to touch base a little bit on skin cancer and the different treatment types, in particular Mohs surgery, because that's the one that gets the most attention. When people think of skin cancer surgery, it's mainly Mohs surgery. It's become mainstream, particularly in the last decade. And then also I'm going to talk about how Mohs surgery led my journey into non-invasive options, beginning with superficial radiation therapy with the Census machine, and how I became, I guess, dissatisfied with the results is probably the best way to put it, and how that led me into electron therapy. And then also I'm just going to go into some of the examples of patients that we've treated and their satisfaction. So the top left picture, that's our group. I'm the good-looking guy in the middle, so that's me. And we have a total of 9 providers. We have 7 doctors right there, and 1 PA. And we're located in the Villages, Florida, which is Central Florida. It's a special retirement community created by the Morse family. And it's a very special community and very tight-knit, a lot of activities. The best way to think about the Villages, it's kind of like Disney World for adults. It's kind of just like a playground for retirees. I believe we're the most comprehensive dermatology clinic in Central Florida. We offer almost everything from medical dermatology, surgical dermatology, cosmetics. We also do vein therapy, and we also doing the electron therapy. So, and we have 3 locations, and I think like our success is just because we try to be the best provide the best dermatology care in our community. So just what we're really here talking about is the non-melanoma skin cancer, basal cells and squamous cells. And as Derek was mentioning, there's millions of cases of non-melanoma skin cancer diagnosed per year, basal cells and squamous cells. There's a lot of different treatment options for these with different cure rates. Mohs surgery is the one that gets the most attention. It claims to have the highest cure rate. There's also other treatments, radiotherapy, electron therapy, regular excisions. There's also cryosurgery, and then topical therapies. Let's go up. I think this, go back to the Mohs slide. Yeah, thank you. So Mohs surgery was something that is a technique that was developed actually about 100 years ago by Dr. Mohs, and it's been refined over the past few decades. But the principle is really the same, and basically it's a skin cancer excision followed by analyzation of all the tissue margins to make sure all the skin cancer has been removed, and the procedure continues until all the skin cancer has been removed. And there's studies have shown that Mohs surgery does offer the highest cure rate. However, this cure rate does vary across physicians, as well as the types of tumors that it's treating, and also the procedures, the processing, tissue processing. You know, for that high cure rate, it does rely on accuracy in resection, as well as mapping, the tissue handling, processing, and most importantly, the histologic interpretation. So, but it does, studies have shown that the Mohs surgery does have the highest cure rate, but it does, in order to get that high cure rate though, there's a lot of variables that have to be achieved. So just the next slide. And so we do a lot of Mohs surgeries in the practice, and this is just a recent patient of mine that had Mohs done about 4 months ago, and he had an infiltrative basal cell in his nose. And so I talked to him about doing the electron therapy versus Mohs, and what they see is that they just see a small biopsy done, because I do small biopsies. So they see a small biopsy, so it can be misleading to the patient on the actual size of the tumor, because the tumor can spread under the skin and you just don't see it. And so a lot of times patients will ask, well, how bad is the Mohs surgery going to be? There's no way to honestly tell them how bad the Mohs surgery is going to be. Mohs surgery in itself is unpredictable, because we're analyzing the tissue and just following the cancer, the spread of the cancer. So, and there's also a recent article. So sometimes these patients, they won't know how, you know, how spread out the cancer is. They just see a small biopsy, you know, maybe the biopsy itself is 3 or 4 millimeters, and they think it's not going to be that bad. There was a recent article in JAMA Dermatology that analyzed Mohs surgery and patient expectations. And they found that over 80% of patients underestimated how big the Mohs defect will be and how big the scar was. And on average, the scar was 2 to 3 times larger than what they predicted. And so a lot of times that's consistent in our practice. The patients, they don't realize how, you know, how large the scar is going to be, or how large the defect is going to be, because of subclinical tumor spread under the skin that they just can't see from the biopsy. So in this particular patient, so I did explain to him about Mohs surgery or electron therapy. I sat down and talked to him, and he still elected to have Mohs over the SCT. And I told him, you know, we have an option where it's not going to leave a scar. So we did the Mohs surgery on him, and go to the next slide. Thank you. And so the Mohs surgery ended up taking 5 stages, and it was followed by a skin graft performed the same day by our plastic surgeon. So you see the size of the defect. Go ahead and go to the next. And so then this is the outcome. So he had a skin graft done, and that was the most recent pictures. And he wasn't happy with the overall results, but he also understands that I gave him, before we did anything, I gave him the non-surgical option before proceeding with Mohs, and that he elected for Mohs surgery over the electron therapy. So even though he's not happy with the results, he knows that he had a non-surgical option that was not going to leave a scar, and still has an excellent cure rate. So so it's a lot easier to manage this patient's expectations, you know, since we gave him that option. And you know, and particularly in this community that I work in, this retirement community, it's a very tight-knit community. And so these unhappy patients that are unhappy with their surgical scar, I know not only find out from them, but I also find out about from 10 of their friends. So, because a lot of their friends come to see me, and I have to hear it repeated, you know, that how this person's not happy with their surgery scar. So it's not this particular case, but other cases like this is what led me to pursue non-invasive treatments. And as I said earlier, I initially started with the superficial radiation therapy, the SRT, purchased from the census. And this is a machine that's designed, it has a small footprint, and it's designed for the dermatologist to operate. So whereas the electron therapy, which I'm going to go in more about, is a multidisciplinary collaboration with a radiation oncology team. So, but I started doing the SRT it's probably back in 2013 or 2014. And I did this because patients like these, they want options. They want non-invasive options. They want to have a choice in what they have and what they're going to have done. Some patients may have a fear of surgery. They're tired of getting cut on. Some just plain hate having Mohs surgery done. They're impatient. They can't wait the 30 minutes to an hour in between layers. And then, others, they're worried about scarring. They don't want skin grafts or reconstructive surgery. There's a lot of advantages, with the SCT, there's no pain, there's no needles. You don't have to worry about bleeding. You don't have to worry about perioperative infections, particularly in patients with medical comorbidities. And we also deal with a lot of diabetics who are poor wound healers, and they get skin cancers on their lower extremities, and they can take 3 months or longer for those wounds to heal. And with all these, it can lead to infection, it can lead to scarring, pain, and ultimately the surgery will lead to poor patient satisfaction and poor patient compliance down the road. So all these brought me to choose a non-invasive treatment. And so I started out with the superficial radiation therapy, which was pretty much all that was available to me at the time. And I did that for 2 to 3 years, and I'd say I was really dissatisfied with the results. I can go in more detail privately with people, but I just don't. But I was just unhappy with the results. Also, it's constantly having my clinic interrupted by having to push the red button. So I was being interrupted throughout the day, having to push the red button, and I'm very busy, so it would slow me down in clinic. And also, if they had questions throughout treatment, I'd have to answer their questions as well, which could also slow my regular clinic down as well. And then lastly, what I really felt uncomfortable about the radiation therapy, the SRT, was that I had this feeling that dermatologists are not trained to do radiation oncology. Like, we had no training in residency. Basically, I felt like, as dermatologists, we don't have our patient's best interest if we're doing the superficial radiation therapy ourselves. So that was just my own personal opinion. I felt like if we're going to be delivering radiation, it should be done by a radiation oncologist. Like, we just don't have sufficient training as dermatologists to be delivering this type of therapy. So I ended up giving up the machine and stopped doing it, and just went back to Mohs surgery. And then my patients would keep asking me about the SRT, why aren't we still doing it? And I have to explain to them. And they would go outside the practice to get radiation done. So a few years later, this is about 2 years ago, as Derek was saying, I looked at different ways, that we could deliver radiation within an office. And I found IntraOp online, and I contacted Derek and asked him about doing this project together, and we got on the phone. At the same time, I was talking to my friend Dr. Brabham, and about doing partnering together, and we were actually Jeff and I, we actually talked about building a bunker, doing an actual radiation bunker that was going to be 2 to 3 times the cost. But after talking to IntraOp, this sounded like it would work. So, but yeah, prior to this, I was thinking about actually building a bunker where we'd actually have to lease another dermatology office, lease another office space, and build the bunker at 2 to 3 times the cost. So anyway, fast forward, 2 years later, we got the electron therapy, and this is a picture of the IntraOp Mobitron machine in our office, and it takes up about, I think it's about 400 square feet. But the beauty of this is that it's a multidisciplinary collaboration with the radiation oncology team, and their sole focus is dedicated to skin cancer treatment, and they do an outstanding job. And in my opinion, it's the best use of the medical and clinical expertise, and has so many advantages for patients, the practice, and the community. And I'm going to go through some of these. But also the advantage of this machine is that it's a small footprint. I think we have about 400 square feet. So and it's great. So and I'm not the one who has to manage it. So I can spend more of my time on patient needs and their outcomes, and making sure my patients are satisfied. So it's just a lot of advantages for patients in the practice and the community. So, and I no longer have to refer them out. We can monitor their progress and also their expectations, and it really ensures their compliance. And all this allows us to deliver superior patient care and outcomes. And most importantly, when we have superior patient care and outcomes, it makes for happy patients and happy doctors. So I'm just going to go through some of the SCT patients that we've treated. So this is a patient of mine that I did a biopsy on his nose. It was a basal cell on the right nasal ala, and that was from January 2020. And I saw him 4 weeks after he finished treatment in April. And I could not tell where anything was done. I looked at it with my microscope, and it was nearly impossible for me to see even where the biopsy was taken. And this guy was thrilled with his results. So very, very happy. And I could not even see where the biopsy was taken. Whereas he had surgery, I guarantee there's going to be a surgical scar there, either a flap or maybe a skin graft. Next patient. This is another patient here that had a basal cell on the right outer canthus, and again, just outstanding results with him. So, and then another thing I wanted to talk about was not just treating the primary tumor, but we can also provide adjuvant radiation therapy. So this is a patient of mine. He's been a patient of mine a long time. He's immunocompromised, or not immunocompromised, but poor health. He has prostate cancer, is being treated for that. But he had an aggressive, deeply infiltrating, poorly differentiated squamous cell on his forehead. And because of the aggressive features, I wanted to send him out for adjuvant radiation therapy. And we can do that in-house. And I explained to this patient, he's been my patient for a long time, and I explained to him, we can do the radiation in-house, or we can refer you outside the practice. I was happy to refer him internally or externally. And it wasn't even a choice for him. He wanted to do it with us, because with us it's convenient. We're close where he lives, and he's already established with our practice. If I had to refer him out, he'd have to get established with a new doc. We have to send the referral, get established with a new doctor. Whereas when it's in-house, I just send an intramail to the SCT group, say, hey, get this guy scheduled for adjuvant radiation. Right away they're scheduled. So he's really happy, and he's going to be starting his treatments here pretty soon. This was another gentleman of mine. This guy, he had an aggressive squamous cell, a poorly differentiated squamous cell on his right ear. And that was the Mohs surgery defect. And because of the aggressive features, we wanted him to have adjuvant radiation therapy, which he had done. And go to the next pager. And so this was after the skin, on the left picture was after part of the skin graft healing. And then the right picture on the right is his ear after the electron therapy was done. And again, he just had outstanding results. I mean, just the results are just outstanding. And I've seen adjuvant radiation delivered, and the results aren't outstanding, but this machine just delivered outstanding results. So just to kind of summarize, this machine, it's well suited for private dermatology practice. I've been very happy with it. Also been very happy with the support from IntraOp, and also the support with Dr. Brabham and his team. Every now and then we'll have some minor issues come up, and we'll get those ironed out like immediately. This is a multidisciplinary approach. It's more affordable, it's less space, and the most thing is just the delivering high patient satisfaction and patient retention, and then the improved continuity care and the patient compliance just leads to happy patients and happy doctors. And I just let Jeff's group take care of it, and I can just focus on what I'm doing here in the practice, and does give me more time to spend with my family. So that's really about all I have to say. So
great. Thanks so much, Dr. Casper. Appreciate that. I think